Okay. Now we will be talking about, in my opinion, the most important topic that we are covering today, quality control in the lab. Okay. This falls under three major subheadings: test methods, biological factors, analytical factors. So let's take them on one by one. Test methods, there are many different types of test methods which are employed by the labs. You have photometry, fluorometry, you have chromatography, immunoassays. So you have some idea, all these assays work in a different way, the mechanism is different, and the way result is expressed is also different. So depending upon what you're measuring, you have to choose the right assay that will give you a proper result. Now, there is always variation in test results. You go to the best lab in the world, you give them a sample with a concentration of a particular substance, ask them to measure, you give the same sample, the next day there will be some difference in the result, right? It cannot be exactly the same. So there is always variation. If the variation is within a small range, we can accept it. Now, how determines this range? And how do we know that this result is valid, it's a quality result, or it is not reflecting exactly what we want the laboratory to measure? So that's why we have to keep these different quality control measures in the lab to make sure that the lab is doing what the lab is supposed to do in the most quality conscious way. Okay, so variations in the test result could be clinical variations, so with the same individual and between individuals, or it could be analytical variations. So let's look at some of the analytical variations now. Anyone knows about this? Anyone have seen this type of what is it called? Sorry? Bell curve. Bell curve is the common name, but the scientific name, the guy who drew it, Gaussian's curve, right? It's called the bell curve, the normal distribution. In any population, most of the people will be here, and then gradually some people will be further away from the center. So this is the normal distribution. When you look at this kind of curve, and you look at, now these tubes here are showing the test which is done many times. Same test done many times. So this is where the test result is, most of the time you are getting the value over here. So this is the highest, the most number of test results coming in this range. Then you have test result coming in different ranges. So you have this kind of a distribution. Now, when you have this kind of distribution, you have to look at three aspects of such distribution: the center, the spread, and the shape. Can anyone tell me what are the measures of center? How do you calculate center of, you have many measurements, different values, you want to know the center. How do you? Mean. Okay, then mode and median. Okay, so you have mean, median, and mode, triple M. All right. Do you know the difference between the three? I'm not a statistician, but just the basic statistics which I think we all should know. Difference between the three: mean is just the average. You calculate all the values here. If there are 100 tests done, all the 100 tests, what are the values? Divide by 100, you get the mean. This is the average, the most commonly used descriptor, mean. Okay, what is median? Okay, so you have mean, you have median, and you have mode. Okay, for spread, how much spread is there? This is the spread now. How much the spread is there? How do you measure the spread? Deviation, SB, right? Or standard error of mean. So you measure it by, of course, the range. First of all, the range. You just take the maximum value and the minimum value. You see the difference between the two. You can know the range. Okay. Then standard deviation is the most commonly used measure of spread. All right. Usually, in a normal distribution, all the values should be within 3 standard deviations. The first standard deviation is 65% of results usually within the first standard deviation, then 85 I think in the second, and 97 in the third. So rule of 65, 80 something and 97. So 3 standard deviations. Alright, and then you have coefficient of variation, which is similar standard deviation, but it is more sophisticated, more complex, so we leave it. Alright. What is the measure of shape? How do you describe the shape? Shape is the curve, bell curve, you said, right? So this is the bell curve. It could be a normal distribution, it could be a skewed distribution, it could be a bimodal distribution. Let's see the next slide now. Okay, so distribution could be normal or bell curve, it could be skewed to one side, it could have two peaks, bimodal distribution. Alright, for normal distribution, mean is the best measure to know the center of the population or the results that you are getting. For skewed distribution, median is the best, and for bimodal, remember mode, bimodal mode. So bimodal mode is the best measure to know where the values are. Okay, in this case you will have two values because it has two humps, bimodal, two modes will be there. Method evaluation. Okay, now every time you use you perform a test in the lab, it should be at the right target, right? This is what we want to achieve, but that doesn't happen all the time. There is always some imprecision and some inaccuracy. Okay, now this is a dartboard, or we want the result to be here, right? We want to nail it in the center. So when you try to, let me try if I can hit it here. Oh no. Oh. So my aim is very bad. Okay. So what is happening now? The target, we are away from the target every time. This is imprecise. But there is one thing very interesting here. If you take an average of all these values, it may give you the right answer, which is in the center. If you look at the distribution of these points, right? Although each point is away from the target that we want, which is in the middle, but if you take an average of all these values, it may give you the answer you're looking for, the center. This is imprecision. What is inaccuracy? Now, if again I try to hit the center, but I'm hitting very close to each hit that I'm making, but I'm not near the center. I'm away from the actual target. This is inaccuracy. So for any biochemical test, it could be imprecise or it could be inaccurate. How would you know? Because as a laboratorian, if the test is not giving you the result that you want, you should be able to investigate why this test is being inaccurate or imprecise. There are certain tests that you can do. For imprecision, you just do a repeated analysis study. So you repeat the analysis many times, you can find out that this assay is imprecise. For inaccuracy, you have to do a recovery study, interference study, or comparison of method study. For example, interference study, sometimes in a sample there is a chemical which is interfering with your actual reaction. If you take out that chemical, your result may give you the result that you want, okay, the target. Comparison of methods, you may not be using the right method for this particular test, so you have to choose a different method. So different ways by which you can investigate why this test is being inaccurate or being imprecise, and you can fix that. Does it make sense? Little bit? Okay. All right. 3 more definitions in this particular topic: sensitivity, specificity, and predictive values. Very, very important when you're talking about diagnostic efficiency. So how efficient is your test in diagnosing a particular disease? Let me show you this through an example, which is from the prescribed textbook that is from LearnLine. You can check the book that has been prescribed for you, and I would suggest that you get a copy of that. Okay. Now, for example, there are pregnant ladies, and we want to check using the beta HCG test, which is the common test, beta HCG hormone levels in the urine. Now there are two possibilities. The patients who are pregnant, when we do HCG test, it should be positive. This is the ideal outcome. If patient is pregnant, the test should be positive. Okay. If we test 10 women and 8 of them are positive, this is a true positive result because the patient is pregnant and the test is positive. We call it true positive. There is another possibility. The patient is pregnant, but the test comes negative. This is now a false negative result. It is a false negative result. In order to calculate the sensitivity of this test, you take the true positives and divide them by the total number of patients, okay, who were pregnant. So in this case, the answer is 80%. So you divided 8 by the total number, which is 10. So it is 80%. This test, beta HCG, is 80% sensitive. In 2 patients, it missed to detect, although they were pregnant. So it is 80% sensitive. For an ideal test, we want it to be 100% sensitive. We don't want to miss any diagnosis, right? Okay, but in this particular example, this test is 80% sensitive. Now, what is specificity? What is specificity? Right now, we are focusing on the true positives. Okay, now we will be focusing on the negatives. Now we have non-pregnant patients. When you do beta HCG test on non-pregnant patients, it should be negative all the time, right? But that's not the case. There are 3 out of 10 who actually show positive result. They are not pregnant, but the test result tells you they are pregnant. Okay, in the remaining 7, the HCG test is negative. So this is the true negatives, and now this is the false positive. False positive. All right. When you calculate this, you take all the true negatives, divide them by the total number of patients. The answer comes to 70%. So this test is 70% specific, 80% sensitive, 70% specific in this particular example. Now I'll ask you one question before we go to the next topic now. If you have to choose between sensitivity and specificity when you are designing a screening test, you cannot have both. Okay, you cannot have an ideally sensitive and specific test. You have to choose between one. Which one you will choose? Would you like to have a more specific test for screening patients, or would you like to have more sensitive test for screening patients? Remember, this is a screening test. It's not a confirmatory diagnostic test. It's a screening test. So you're screening the whole population, 100,000 people. You want to screen them. So in this case, sensitivity is more important. Why would you say so?
Just a large number of people.
Okay. So for example, if you are doing screening, let me give you a practical example. Doing screening for HIV, for example, right? So would you prefer to have some false positives, and then if there are few false positives, you can send them to a better lab and do a screening, do a proper test and tell them, okay, you are safe, go back, you don't have HIV. Or you can miss some patients in screening. They were HIV positive, but the test didn't pick it up. Which one you would rather choose? You will go with some false positives, right? It's a screening test. If there are few false positives, no problem. You call them to a proper lab, you do a confirmatory test, and you tell them good news, okay, sorry, it was a false alarm, you're okay, go back. There's no risk to the population. But if you're doing a test which is more specific, you miss the patients with HIV, what will happen? After a few years, the HIV incidence in the community will go up, you miss the patient. So for screening tests, you go for sensitivity. For confirmatory tests, you go for specificity if you have to make that choice. Does that make sense? Okay. There's one more thing now, which is called predictive values. Now we're going to align them in a different way. We're going to align them now for the test. So, this top row is all HCG test positive. So, out of these all HCG test positive, okay, 8 of them are true positive, 3 of them are false positive. Okay. Now, these patients have got the result and they come to you, you are sitting in the lab and they ask you, can you explain our result to us? Okay. If the result is positive, what would you tell them? Any one of them showed up and asking you, okay, I have this positive result, so what does it mean? What would you tell them? You're pregnant, but 3 of them are not, right? 3 of them are not. You don't know. You have to explain the result to them now. How do you explain it? You have to save your neck, right? Yeah, it will be useful later.
Well,
Okay.
it's like an
So
8 out of 11 chance that
exactly. So what you tell them, okay, the test that is positive, there is 72% chance you might be pregnant, but there is 28% chance you may not be pregnant. So based on sensitivity and specificity data, you calculate predictive values. And when you are counseling the patient with the test report, test result, of course you can't tell them, my report is final. Nobody can question our lab report. You have to tell them based on statistics, based on data, that okay, there is 72% chance that you are pregnant, but there is 28% chance you may not be pregnant. Same thing for negative predictive value. The patient has negative HCG test, but you still tell them that there is 78% chance that you are not pregnant, but there is some chance that you may be pregnant. Our test has missed to pick the beta HCG levels in your urine sample. Okay? So these things are important when you are interpreting the report and when you are communicating with the patient or the doctor. All right? Does it make sense now? The statistics? It's important to know a little bit, right? Agree or not?
Doesn't it depend actually how common the disease is? Because if it's a very, very rare disease and the test has a high, a 1 in 10 false positive rate,
Right.
it's much more likely that the test is wrong than that you actually
Yeah.
have the
Okay.
disease.
Actually, this when you look at predictive values, the population also makes a difference. How big is the population size? How common is this illness or disease or whatever thing you are looking at? So there are these factors as well. So what I am telling you is just the basic of these concepts, but of course what you are telling is also important. And if you look at the chapter from where I've taken all this, it's a scary looking chapter. Yeah. So I wouldn't expect you to go through the whole chapter, but at least these terms that I've mentioned, at least try to read more about them and try to understand. Okay? All right. Did you get your answer?
Yeah.
Or kind of?
It's not factored into that.
No, not in this one. Yeah, it should be if you're looking at a big population, and then definitely. The first factors of quality control, the first category, which is the test methods. The second category is biological factors. What could these be? Again, they are divided into 2 categories. Inter-individual variation. So if you take a sample from a 10-year-old boy compared to a 70-year-old man, the values of a particular substance may vary. So there are differences with age, with sex, with race, with genetics. Long-term health status can lead to some changes. There is also intra-individual variation. Diet. Okay? If you are going for blood lipid levels, okay, and if you had these extra large fries from McDonald's, right, your report will be different from if you go there after having green vegetables. Okay, so your diet will make a difference to your result. Exercise level, different drugs if you are taking, sleep pattern, posture. Posture very important. There are certain things which can actually change with posture. When you are lying down or sitting, the blood is flowing into your veins and arteries. If you stand up, a lot of blood gets pooled into the veins of lower legs. Almost 600 to 700 ml blood gets pooled into the lower limbs. If you take blood sample, then the concentration of certain substances may have changed. So posture is also very important. Time of venipuncture, length of time tourniquet is applied. You know, tourniquet is applied to make the veins more prominent. And if you apply the tourniquet and you forget to remove it, okay, or you take it long time before you take the blood sample, again it could lead to variation in results. So all these things are very, very important. As you can appreciate now, there are so many variables when you are collecting the sample, to analyzing the sample, to reporting the test result, that a proper quality control mechanism is very, very important if you want to give a proper result to the patient, right? Analytical factors are divided into three major categories: pre-analytical, analytical, and post-analytical. There could be mistakes anywhere. Okay, let's look at some common examples. Pre-analytical variation could be in the transport, took too long time to reach the lab. Okay, exposure to UV light, standing time before separation of cells, centrifugation time, storage conditions, the temperature is not proper. So all these factors will affect the quality of your test result. Analytical variation could be random errors, could be systematic errors. If you are running an automated machine, if the machine has not been serviced regularly, you know, it is giving way off results. These are analytical errors. Post-analytical, transcription errors. You said something, your transcriptionist wrote something else. Okay, or you have given wrong report to the wrong patient. Okay, so these are post-analytical errors. Pre-analytical errors. Can you think of any additions? What I showed you in the previous slide. What could be pre-analytical errors? Anyone? Okay. So you were supposed to collect the blood in the tube where it doesn't coagulate, but you put it in the tube where it clots. So the sample is of no use. Okay. Venipuncture performed correctly, specimen properly stored. So patient ID is very, very important. Okay. So you have, nowadays usually there are 2 to 3 checkpoints: patient's name, ID, age, etc. So you have to check all those so that you don't mix up samples. Okay. Again, you know, you have to put the sample in the proper tube. Nowadays the tubes are color coded, so you know which sample goes in which tube, and of course they have all these barcodes that are scanned in the machine, so the data is always stored securely, and you know there's less chances of mixing the specimen. Prolonged venous stasis, again the tourniquet I was just mentioning to you. If you leave the tourniquet for too long, you know, it can lead to the sample you can end up with increased proteins, iron, cholesterol, bilirubin, or decreased potassium. So this is a possibility. Again, the position of the patient, whether the patient is lying down, sitting, or standing, can also lead to a lot of variation. So these following analytes may decrease by 5 to 15% in the supine patient. So when the patient is standing, they will be slightly higher in concentration, or sitting. All right. So usually we know that these samples are collected when the patient is either sitting or lying down, not standing. But if there is a special situation, you have to make a note that this sample was collected when the patient was actually standing or whatever. Okay. Special handling. These specimens, if you are going to measure these 4 items, for example, it should be immediately placed on ice. Otherwise, your result will not be valid. Okay, just giving you some examples, you know, of how important it is to know all these steps from the time the sample is taken from the patient to the time it reaches the lab, and then it is reported. Hemolysis or rupture of RBCs can also occur if the collection is not so good. Okay, it can lead to increase in potassium, magnesium, and phosphorus. Can anyone tell me why these 3 will increase in case of hemolysis? These ions are much high inside the cells than outside the cells, right? If the cells rupture, you have all these ions coming into the plasma or serum, so you will have false high readings, especially potassium, very important, okay? Because potassium is very high inside the cells. If cells rupture, all the potassium will leak out and you will have a false high reading of potassium. So these factors are very, very important. Interference, if there is hemolysis and hemoglobin leaks out from RBCs, it can interfere with many different substances, and test results will not be good. Some test results are used by looking at the color change. So if hemoglobin is there, it is red in color, it will interfere with colorimetric tests, okay, so on and so forth. If there is lipidemia or proteinemia, and the serum or plasma becomes turbid, it will also affect the results, okay. Any questions about the quality control and the, you know, all the three aspects of quality control? The take home message is that all these steps are important. So if you miss one, no matter all the others are in place, it can jeopardize the whole process, right? The test result will not be valid anymore. So you have to be very, very careful that all this these chain of events is quality assured, okay, and there is proper communication between all different people who are involved in this whole process, right?
In quality
Yes.
control, do all labs follow a specific procedure?
Yes, there are guidelines
From the central body?
from a central body. Yes, the guidelines are there.
Is that AIMS or?
In Australia, I think it is AIMS, depending upon different types of laboratories. So pathology laboratories from Royal College of Pathologists of Australasia, RCPA, will have the guidelines. Yeah. And these guidelines are regularly updated. If there's anything new, they always come up with newer guidelines. Yeah. Okay. But in addition to those, you have to have local quality control system in place as well, because each lab is different. You know, the design, the location. There are certain logistic, factors that these general guidelines cannot factor in. So you have to then think about those as well, right? Yeah. Point of care testing. Now this is where you can actually test at the point of care where the patient is. So you don't have to take the sample all the way to the lab. You can do the testing where the patient is. This is point of care. So can you think of any examples? Point of care testing? Anyone?
Blood pressure.
It will not come under clinical biochemistry, but okay.
Would that be the dipsticks?
Yeah. Big drug
Dipsticks?
tests, yeah.
Okay.
Like
Alright.
marijuana and all that. It's drugs.
Okay. All right.
Blood glucose?
Sorry?
Glucose levels?
Blood glucose levels, Yeah.
Oxygen saturation?
oxygen saturation. Yeah. So all these tests are basically, so blood glucose, urinalysis with the dipsticks, blood gases in the emergency room, because you don't have time to take the sample. So you should have the analyzer there. You can do blood gas analysis there. Electrolytes, cardiac markers. If somebody is having myocardial infarction, you should be able to do it there and then, so that the treatment can be monitored, can be changed according to that. Sometimes drug screens, if somebody is having a drug poisoning. Okay. Now this table is from the book actually, the disadvantages and advantages of point of care testing. There's a long list and there's a long debate whether point of care testing is useful over the core laboratory. And of course there are certain situations where POCT is important, but there are certain situations where POCT does not replace the core biochemistry laboratory. Okay. The cost is lower, the time taken is lower, but the validity of the test may not be that good. The quality check of the test may not be that good. Then communication with the core laboratory, etc., there are some issues. So you can read this on your own. There are many questions, who is going to pay for the instruments and reagents, who is going to conduct the test, who is to perform the necessary quality control, does the instrument interface with the hospital LIS, so it can communicate the data to the central data in the hospital, or is it something printed that you have to go and enter into the system. So these are some considerations that you have to take. Okay, so things like cardiac markers, drug screens, urinalysis, these are certain things which can be tested at the point of care. Okay, and even USB powered devices can be used, point of care testing, personal level. All right. Any questions or any concerns? Okay, all right, then this is the main reference, the book that will be following during this unit. Okay, thank you very much. If there are no questions.